Good morning again, everyone. It's Melanie Mock and Emily Henderson from Kentucky Hospital Association. Thank you so much for joining our Kentucky SOS webinar today. We have a wonderful speaker, Dr. Connie White, who will be presenting for us today. Just a few housekeeping items. We are recording the call today, so please, if you can, please mute your phones by hitting *6 on your phone or hitting the mute button. We ask that you please do not put us on hold, as we will hear your hospital advertisement or your music from your hospital. The recording of the call and the presentation will be available to you after today. If you would like to download the presentation and a copy of the continuing education credit information, you can go to the media library, which is the third icon at the top right-hand corner of your screen. Go to shared files and then download a copy of the webinar slides today. If you have any technical issues along the way, please feel free to email me at mmoch@kyha.com. You can chat in the chat box anytime with questions, but we will allow time at the end to answer all your questions. At this time, I'm going to turn it over to Emily Henderson to introduce our speaker. Emily?
Thank you, Melanie. This is Emily Henderson, pharmacist with the Kentucky Health Association and project lead for the Kentucky SOS program. Kentucky SOS welcomes you to this monthly webinar, and I have the honor of introducing Dr. Connie White. Dr. Connie White practiced as an OBGYN physician in Frankfort, Kentucky for over 20 years. She retired at the Kentucky Department for Public Health as the director of the Division of Women's Health, and then she joined the College of Public Health as clinical professor at the University of Kentucky for a period of time in the Department for Health Behavior. Dr. White returned to the Kentucky Department for Public Health as Deputy Commissioner for Clinical Affairs in 2014 and continues her work today. She has served as principal investigator for several grants that included diabetes, heart disease and stroke, colon cancer screening, medication for opioid use disorder for pregnant and parenting women, obesity, physical activity, and a host of others. Kentucky SOS welcomes Dr. Connie White. Dr. White?
Thank you so much, Emily, for that kind introduction. This is a very exciting day for me. I told my husband when I left this morning, this is something that I've been looking forward to for quite some time. In the partnership between Kentucky SOS, the Kentucky Hospital Association, and the Kentucky Perinatal Quality Collaborative. I think that the Kentucky Perinatal Quality Collaborative, or PIPQC as we call it, has a lot to offer for all the women and mother and babies in Kentucky. Our motto is making Kentucky a great place to have a baby and a great place to be born. And I think that the work that you're doing in SOS blends nicely with this, and I'll explain that to you moving forward. So how did the PIPQC, the Perinatal Quality Collaborative in Kentucky, come to fruition? In November of 2018, Kentucky was invited with 11 other states to come to Washington, D.C. at the invitation of ASTO. ASTO is the club, if you would, of all the Dr. Stack. Dr. Stack is our commissioner for the Kentucky Department for Public Health. So it's a club where all of his colleagues get together and work on public health at a national level. So ASTO has initiatives all the time for different projects, and Kentucky was invited to be part of the OMNI initiative, which stands for Opioid Use, Maternal Outcomes, and Neonatal Abstinence Syndrome Initiative. We were invited to bring those first five organizations that you see on this list. They wanted us to bring someone from our Kentucky Department for Public Health Commissioner's Office, so I attended. Maternal Child Health Division at the Department for Public Health, Dr. Henrietta Bada, attended that with us. Also, they wanted someone from behavioral health, from Medicaid services, and from the Kentucky Hospital Association. So that group of 5 people went to Washington, D.C. We had experts come and talk to us about opioid use, maternal outcomes, and NAS, neonatal abstinence syndrome. And then they had us break up into state groups and say, what would the one thing do? What would the one thing be that you could do in your state to try to tackle all of these issues under the OMNI initiative? And it was very clear to us that we needed a perinatal quality collaborative. I'll explain to you what that is a little bit in just the next slide or two, but the group came back, got very excited. In year 2 of the Omni group, we added the Kentucky Primary Care Association, and then when we came back from that meeting, August of 19 from D.C., we decided we couldn't do any of this work without having the Department for Community-Based Services, which is where Kentucky social workers live, unless they were involved. So what you see in front of you is the Kentucky Omni team. So why do we need a perinatal quality collaborative? I think this slide describes it extremely well. This is a mortality rate from California that goes from 1999, and 2013 was the last data I could find on their website. But what it shows you is that in 2006, they had a tremendous spike in maternal mortality rate.
With a friendly staff that's eager to serve you, Wayne County Hospital's vision is to be your healthcare provider of choice.
Dr. White, hang on just a second. I'm going to mute all lines. Hang on one second,
Thank you for continuing to...
Presentation mode is now enabled.
Okay, Dr. White, you can now continue.
I figured if we listened long enough, we could figure out who it was, but that's okay. So in 2006 in California, they had a huge spike in maternal mortality, up to 16.9% of live births. As you can see on the graph, the blue line is California and the red line is the United States. So in 2016, the Department for Public Health in California worked with Stanford University, and they developed their Perinatal Quality Collaborative. And as you can see, over those next few years, their maternal mortality dropped to 55%, while the rest of the United States rate continued to go up. This is testimony to what happens when you pull all the right stakeholders together in the same room and get them working together. So here we have the Kentucky Perinatal Quality Collaborative logo, and we thank the Kentucky Hospital Association because they graciously provided this graphic art for us, and I absolutely love it. But what a Perinatal Quality Collaborative is a common table that brings representatives from healthcare providers along with birthing hospitals and insurers so that they can sit and look at the data. They can see if there are evidence-based solutions that could lead to policy change and result in improving outcomes. So that's what the Quality Collaborative does. And since we came back from DC that very first time and we decided that PQC was, or PIPQC was what we needed, they all looked at me and said, how are we going to pay for this? Because if you're going to have a PIPQC, you have to have somebody, a central office, who is answering the phone, scheduling the meetings, keeping the minutes, making sure that all the committees move forward. So what we did was we formed a steering committee, and Melanie Mock is on that. The steering committee is composed of people from the March of Dimes, the Kentucky chapter of sorry, I just went completely blank. The Kentucky chapter for pediatrics, the Kentucky section for ACOG, A1. We have about 13 different representatives from different size birthing hospitals. We have a representative from private industry. We have a representative from Kentucky Department for Medicaid Services. And this is our overall steering committee. This committee is not a Department for Public Health committee. This is the KIPQC committee. And they are the ones that determine the direction we want to go and guide us. That committee now has been appointed 3 different work groups. We have an OB work group, a NEO or neonatal work group, and a quality work group, the quality and data work group. And all 3 of those work groups are pulling together what data already exists, so we're not laboring you with more data requirements, but what data do we already have that exists that could give us some input on, especially the opioid crisis, but then all the other problems that face new moms and babies in Kentucky, and how can we drive all of those different partners, the nurses, the doctors, the nurse midwives, the certified nurse midwives, the pharmacists, how can we drive everybody in the same direction to improve outcomes? Well, I'm hitting the wrong button here. So what's been found in other states is a program called the Alliance for Innovation on Maternal Health, or AIM. AIM is a national group that got together and pulled experts together and said, all right, if we have a problem such as hemorrhage in maternal, in the postpartum period, what are the protocols that need to be followed? What policies can we institute? What's the training? How do we educate? What are the checklists? And this Alliance for Innovation, or AIM, pulled together several bundles that they call them. And if you belong to AIM, you can either apply for the pulmonary embolism bundle, the hemorrhage bundle, the depression and anxiety bundle, but they also have an obstetrical care bundle for women with opioid disorders. And because of Omni's charge, we felt this would be something that would be helpful for Kentucky. So in order to really make change, you need three different pieces. You need a maternal mortality review committee, looking at all of your deaths, doing chart reviews, trying to figure out why did these women die, were there changes that could have happened in their care, and this maternal mortality review committee looks at you from the time you're pregnant until you are 1 year past delivery, and was your death pregnancy-related or other, and what changes would they recommend policy-wise that could have made a difference in this woman's life. That committee really can't do anything unless there's a PQC that it can send that to, which can then work with the AIM initiative in the delivering hospitals and the provider offices to make all of this come together, change culture, and improve the outcomes for moms and babies. This is some preliminary data from our Maternal Mortality Review Committee. The legislature passed and allowed us to develop a Maternal Mortality Review Committee in Kentucky that is protected. We've been doing maternal mortality review in Kentucky for many years, but it was not a protected committee, meaning anyone could get those minutes in reopen records. And it did not, as you know from being hospital people, that doesn't allow for the kind of open discussion that we really need. So we were able to put maternal mortality review in with the child fatality review structure. So now we have a separate committee for maternal mortality that Dr. John Barton, who is a maternal fetal medicine specialist at Baptist Health Lexington, is our chair. So we were started by looking at the 2017 deaths, and this graph was produced, the report was due to the legislature before we had our last committee meeting. But this just shows you kind of a breakdown of where we saw those maternal deaths. And if you look at this, you would say, well, only 31% of our deaths, although that still is the biggest piece of that pie, are drug overdose or drug intoxication. However, what that doesn't show you is that some of these deaths of these women are overdose deaths. Some of them are a cardiac complication because of overdose and damage to a heart valve from sepsis. And some of the motor vehicle wrecks also had drugs involved with those wrecks. So if you add all of those causes together, actually 53% of maternal deaths in Kentucky in 2017 had a substance use disorder factor of some kind. So we can clearly say that substance use disorder is the #1 killer of women during and in the first year after pregnancy in Kentucky. So this led me to, in the reading I was doing, was looking at a study that Vanderbilt was doing, looking at use of drugs in the postpartum period. And I know quite well in our cabinet we have the CASPR data. CASPR, as you know, is where we record all of the opioids that are being prescribed by physicians across the state or providers across the state. So we asked for an evaluation. I wanted to be able to show that over the last few years that physicians and nurse practitioners in Kentucky were prescribing fewer and fewer opioids as we became more aware of the opioid crisis and the substance use crisis in Kentucky. However, when I asked Dr. Baronis to look at this, he came up with some parameters that he wanted to use to make this a very pure study. So what he did was he looked at Kentucky residents only. He looked at our Office of Vital Statistics to get our birth data, and then blended that with his CASPR data. And then he got really exclusive. He excluded anyone who had had a blood transfusion. He excluded anyone with a perineal laceration, so nobody more than a first or second degree episiotomy. He excluded anyone that had an unplanned hysterectomy or any other unplanned OR procedure. No one with an ICU admission, and I don't have it on here, which I'm surprised I didn't put this. He only was looking at women who were having a first birth. So if this was your second or third or fourth baby, he didn't include you. He just looked at women undergoing their first birth. Unique mothers means that if I delivered in January and I delivered again in December, I was still counted as one person. He used Social Security number and date of birth as different factors to be sure his data was accurate. And then he excluded buprenorphine. So we weren't looking at people who were in treatment. We were looking at people who were getting an opioid prescribed to them within 7 days after their delivery, whether vaginal or C-section, and for first-time mothers only. Now, this is a really busy slide, but I'm going to just kind of talk through it, and then I'm going to break it down by method of delivery. But, oh, that's right, you can't see my arrow. So the first column is the year of delivery. The second column is the numbers of deliveries. Now, we have about 50 to 55,000 deliveries a year. So you can add up in your head, this is not all of the deliveries. But remember, that's because we excluded people that had complications, people that might need higher levels of opioid, might or might not. But we wanted to exclude that. So this is truly looking at first-time mothers with uncomplicated deliveries. Column number 3 shows the percent of those prescriptions that were actually filled. Like in the first line of those 10,223 cesarean sections, 73% of those women filled their prescription. The next column shows you the average number of pills that were prescribed in these prescriptions and the daily average of how many pills this would average out to over a 7-day period. And then it gives you the daily MME average for each of these categories. So first we're going to go to cesarean sections. So these are women who had a cesarean section and had a prescription filled. And if you look over the time frame from 2014 to 2019, you see that the number of, or the percent of women who got a script filled was around 73, 74, about the same. However, if you look at the daily MME, it did drop some, but those are still awfully high numbers, 58 in 2014 down to 48 in 2019. The total number of pills that were prescribed, column number 4, did drop by 7 pills. Daily average number of pills prescribed stayed around between 4 and 4.5 pills. That's for cesarean sections. If you look at that for vaginal delivery, what you find is that the percent of women who got a script filled dropped by 14%, and I thought that was very interesting. I've presented some of this data before at a different meeting and afterwards, since I was in practice for 20 years in Central Kentucky, and a lot of women that work here at the state were patients of mine have come up to me afterwards and said, well, you delivered my baby and you didn't give me any opioids. And I smile and say that's exactly right, because opioids are not really recommended for an uncomplicated vaginal delivery. So if you look here at this table, you can see that, as I said, in column 3, the percent of women who got a script dropped dramatically, I think, between 2014 and 2019. But the total number of pills did drop from 24 to 17. The daily supply is about the same, but the daily MME dropped by about 10. But still, we're looking at a first-time mother, uncomplicated vaginal delivery, getting a daily MME of 36.3. Now, when I do this presentation in some circles, I explain that very carefully. Everybody on this call knows what an MME is and knows that that level is pretty high. So in this table, I just wanted to show you over that period of time the total number of pills that were prescribed. So that's 71,772. Now, you read different articles that say how many pills women actually take when they go home from the hospital. And by and large, women that have C-sections or vaginal delivery do not come close to using all of that medication. In fact, most articles that I read, 50% usage would be high. So if that's the case, there are 36,000 pills in medicine cabinets all across the state of Kentucky that we are providing to women who will not need or use them, and those are just there available for someone to either divert or, to me more scary, get into a medicine cabinet and take them themselves. So this is a different way of looking at the percent of prescriptions that were filled. So the green bar is the women that are having a cesarean section. So you can see that that's still over 70% of them get their prescription filled. But you can see a little bit more dramatically how that vaginal delivery, women are getting more and more concerned. You have to remember, these are just women that got the prescriptions filled. Lots of people I talk to say, well, the doctor gave me a prescription and I just didn't get it filled. So this is very much an underrepresentation of how many opioids are prescribed for routine OB/GYN or OB care. Now, Dr. Bronis did these graphs for me, or these table graphs for me. And this is the first one, just shows you the average MME by C-section in red and by vaginal delivery in blue. And it looks like quite a drop, but as we talked about before, over that period of time, it hasn't been that big of a drop. And even still in 2019, we are at a much higher place than we need to be for opioid prescribing for vaginal deliveries and cesarean sections. This graph here shows the same data that I showed you before, but not in a table, but in a graphic form, and it shows you the average daily supply. So although that red line looks like a drop, you really are dropping from 4.5 to 4.1. That's not even a whole pill. And then the blue line, this vaginal delivery, is going from 3.9 to 3.3. Again, not even a whole pill of a drop. We're still prescribing quite a bit of medication. And then this last graph just is looking at what I showed you earlier in table form, and that's the total number of pills prescribed. So in cesarean section, we went from 30.9 to 23.9, so that is a drop of 6 pills. Oops, I'm going to do that. But in the blue line, you can see that there was a bit more of a drop in the daily supply, or in the total number of pills, but still not very dramatic. So in our Casper data, we can actually look and know where this prescriber is delivering, where's the practicing hospital. So I did take the names off of these because that was not the point of the talk today. But you can see here that this waterfall graph shows you delivering hospitals, the number of patients that filled a prescription in 7 days after their first uncomplicated singleton delivery. This combines C-sections and vaginal deliveries. The blue line is 50.5, so the average MME for both of those procedures together is 50.5. And the darker the bar, the more deliveries that were done in that particular hospital. So you can see that at the top, some of the higher ones are people who are hospitals that deliver more babies. Then there's a mix through the middle. I will tell you that the bottom 6 on this chart, 5 of them are in eastern Kentucky, which I thought was very interesting. I didn't graph it out for you, but that just tells me that the folks in the eastern part of the state who have been initially hit the hardest by the substance use disorder crisis are understanding that this is an issue. But still, even the hospital with the lowest amount of MME prescribed for C-sections and vaginal deliveries has an MME of 29. Now we're going to look at these waterfall graphs strictly by cesarean birth only. So that average MME is 55.8, and you can see that ranges from 33.2 all the way up to 75.3. 75.3, that's just remarkable to me. So that's cesarean deliveries, and again, the color of that red bar depends on how many deliveries are done. And you know what? I think I told you exactly the opposite before. The lighter the number, the more deliveries. I need new reading glasses. So the lighter the number, the higher number of deliveries, and so that follows here. So the lighter bars are the hospitals that delivered the more babies, and the darker the bar, the fewer babies. And then if you look by, this has an average MME of 42.5 in women who have a spontaneous vaginal delivery. The lighter bars is the heavier numbers, or the higher numbers. It's interesting on the C-section one, when I did a little map on my own, one of the highest and one of the lowest was in the same town. So geographically, it doesn't really follow, except for what I said earlier about the lower numbers, the lower end of the MME scale being hospitals in eastern Kentucky. So I did some digging around, and I looked at different studies, and you can find a whole range of information that tells you if someone is exposed to an opioid, what is the likelihood that that person will continue to persist opioid use after they've delivered. So I looked at our table from before, and I added up all the deliveries over this period of time. So there would have been 39,460 cesarean sections and 30,147 vaginal deliveries. One study I read that says 1 in 300 people that are exposed to an opioid will become a persistent user. So that's the third column. So of those C-sections that we have talked about, 132 women could have become persistent opioid users because of our prescribing technique, and 101 vaginal deliveries. I just read an article this morning that said it's 1 in 16. So that's a very big range. But even being the most conservative, that is 233 women that have been exposed to an opioid that might become persistent users that were never using before. Another article that I read that was very obese specific said that 0.84% of women who have a C-section that take opioids and 0.59% of women who have a vaginal delivery will become persistent opioid users after being prescribed. That number, as you can see, then gives us a much higher number of women over time, around 600 people, 500 people. I'm trying to do the math in my head. I should have added this up before. That will end up being persistent opioid users simply because we prescribed an opioid for an uncomplicated vaginal delivery in a first pregnancy. In 2015, I was in Washington, D.C. at an ACOG meeting, American College of OBGYN, and I was asked to lead a breakout session on opioid prescribing in the postpartum period. As I said, I haven't done deliveries since the 2000s, and I knew that for vaginal deliveries, I didn't prescribe any opioids, Tylenol, ibuprofen, ice pack. And for cesarean section, I would usually prescribe 10 pills and tell people, if you need more than this, there must be something wrong, and I want to see you in the office right away to be sure there's not a complication. And that was pretty much my standards, 10 to 12 pills that I would send someone home with. So I led this work group. This was 10 years after I had stopped delivering, and I just innocently said, so how many, and they were mostly residents in training, how many pills do you prescribe for a vaginal delivery? And universally, and these were people from all over the country, the answer was 40. And you had to pick me up off the floor. 40, lower tab 7.5 was what the average resident told me that they were prescribing. And when I got my breath back, I said, why in heaven's name are you doing that? And they had a whole host of reasons. That was right after they had taken off pain control as one of the factors that patients would give you on the survey with how was your hospital stay and was your pain under control. That had been removed, but that was still a culture that people in hospitals felt that they had to be sure that people had no pain at all if they were in the hospital. That wasn't very long ago, but for the group that I'm talking to, that seems like eons ago. Then there was a lot of peer pressure. There was, well, I have to do what my chief resident tells me to do. And as having been a resident, you pretty much mirrored what the people above you did and told you to do. Another interesting answer I got was, well, if I don't, then the nurse asked the patient, what's wrong? Doesn't Dr. White like you? Why did she not send you home with some pain medicine that will control your pain? So there were all kinds of different reasons, but for the residents, they just pretty much didn't know there was anything else to do. They thought this was standard of care. So since that interaction that I had back in 2015, there have been lots of guidelines that have come out. Johns Hopkins in the last couple of years came out saying that in uncomplicated vaginal delivery, the recommended guideline for opioid discharge use is 0. So I felt a bit justified that I'm not just an old dinosaur, that really is a medically appropriate thing, appropriate way to treat a patient. So I think part of what you found in all the work that you folks are doing is that healthcare providers are trainable. You've seen that in the work that you've done. And I went in just a real quick, oh, there's my totals. I thought I did that, 509. Sorry. Just a real quick conversation with Dr. Google. I was able to quickly find 3 articles that talked about different training programs that they have done, sometimes in large hospitals, sometimes in smaller hospitals. One that I just looked at this morning was in a community hospital, and their point being was that in a lot of training facilities, large universities, you can do these kind of training programs, but there's not a lot of work in community hospitals. And this was a community hospital in Michigan that found that they reduced the number of pills prescribed 60 to 70% just by doing a range of instruction to providers to understand better what the best outcome for their patients would be if they did a more succinct way of prescribing. So what I come here today is to ask, and I've talked with the Kentucky Hospital Association. They've been very helpful. As the Kentucky Perinatal Quality Collaborative looks at the leading cause of death of pregnant women in the state of Kentucky, 53% had some type of substance use disorder factor in 2017. We're not finished with 18. We're working on that right now, but we think we're going to see the same numbers. So as we at PIPQC work with the Maternal Mortality Review Committee on opioid prescribing, as we begin to apply to become an AIM state and apply for that maternal opioid use bundle, which will give us tools that we can help hospitals with training people about standards, is there an opportunity for us at PIPQC to work with the SOS program and get into those delivering hospitals? I don't want to use the word educate. I've stopped using that, and it's public health. That's kind of what we do all the time, but I don't think we need to educate folks. They're pretty well educated right now, but they're not clearly informed. They're not informed of the guidelines that are the standard for prescribing in a postpartum setting, and they need to be informed about the chances of these women who are not substance use disorder patients beginning to take opioids or whatever drugs are available in a persistent way. So I think if that's clearly laid out to providers in all of our birthing hospitals, to our nurses, our postpartum nurses, our nursery nurses, our pharmacists, certainly our certified nurse midwives, all the people that touch this patient, if we're all working in the same direction, excuse me, all working in the same direction to say, yes, childbirth is uncomfortable, and sometimes it just flat out hurts. And we have no intention of people going home and being in exquisite pain. However, as you've done with SOS and your trauma services and other parts of your hospital, we do a lot of surgery in OB. And if we can master what you've done with other disciplines and do that with our postpartum and our obstetrical population, teach them different ways of managing their pain, different expectations, I think that is extremely clear, then I think we can actually make some headway on this issue. I know when my mother entered the hospital, it was last summer, they asked the typical, what's your pain level? And she's a hospital veteran. She knew exactly what number to tell them, and she said she was a 6. And then the next question surprised me. It's probably not, I'm sure, a surprise to you folks, but they asked her, what pain level would you be comfortable going home with? And my mother, who's 90, immediately said, oh, I could do a 4. 4 would be fine. And I asked the nurse about that questioning, and she said, when I have a 19-year-old in here and he's had a broken leg and he wants to go home with a pain level of 0, I tell him this is not going to happen. That is not how life works. So I think that, as y'all have found, that expectation of no pain is an important role in obstetrics, just like it is in your surgical patients. So we are offering to work with the AIM bundle and work with trying to find different training modalities that we could provide, online resources, checklists, posters, all of the things that you all know is important in changing the culture, because we are talking about changing the culture here. Just 15 years ago, when I was delivering a baby, if you had prescribed 20 or 25 opioids for a vaginal delivery, everybody on the floor would be coming to me wanting to know what was wrong. What was I thinking? That was not the culture at all. And so we've got to revert that culture back, because we don't want to be the ones responsible for exposing opioid naive, or even people who've used opioids before, but giving them the opportunity to use more opioids in their life than is necessary. So I'll show you the group. This is the group that's gotten together to work on, these are our supporters in the PIPQC, the Kentucky Perinatal Quality Collaborative. We have great hopes that our work groups are coming up with projects. We're going to present that to our steering committees and get their blessing, and then you'll hear more about us. But I just wanted you to know that this is a grassroots group. There's been so much great enthusiasm. This is definitely a pent-up need in the obstetrical community, and we see the Kentucky Hospital Association, which has been a great partner up until this time, but our work with SOS could really be a great stepping stone for your project, as well as for us to be able to get into the right places and get that information to our providers and to our hospital staff, so they can understand how important this role is for all of us to play. So this is my contact information. As Emily said, I've been here at the Department for Public Health for quite a while now. It's kind of strange when I hear someone say that, but I think we are on our way to building a KIPQC with a central office staff that are going to be available, because the KIPQC is not us. The KIPQC are the hospitals and the providers out in the community that will find ways for us to make Kentucky a great place to have a baby and a great place to be born. We have several webinars that we do monthly. We have one coming up, in fact, Friday afternoon. Dr. John Barton, I mentioned earlier, is going to do a webinar on COVID-19 and pregnancy. We have a monthly bulletin. We don't call it a newsletter, but a monthly bulletin we send out to staff. So anybody that's interested in getting on that listserv, we would love to have you participate. We had our launch last October. And the exciting thing was not only did 250 people come to Churchill Downs last October, at the end of the meeting, we started at 8:30, and by 4 o'clock, we had still over 200 people in the seats because everybody understands how critically a perinatal quality collaborative is to the state of Kentucky. So I will stop now, and I haven't been looking at the chat box looking at questions. I've been trying to stay focused on my presentation. So I'm very happy to ask any questions that someone has chatted in, and any further conversation down the road. This is how you can get in touch with me.
Thank you so much, Dr. White. This is Emily Henderson again. And you are exactly right. Kentucky SOS is delighted to be partnering with the Kentucky Perinatal Quality Collaborative. As all of our attendees are aware, and our participating hospitals are collecting and submitting data monthly regarding metric 4B, which is select surgical procedures, which is the uncomplicated vaginal deliveries. We do know that there are opportunities in our state, but wonderful actions are happening daily, and prescribing habits are changing regarding this. So we look forward to the data coming in and evaluating that. So with that, we will open up the lines, please. Melanie, if you would do that. And would anyone...
Presentation mode is now disabled.
Would anyone please share their policy or protocol that they may have in place for 0 days of opioids prescribed for the uncomplicated vaginal delivery in your facility?
All lines are now unmuted. You can hit *6 to unmute yourself, or hit your mute button on your phone to speak, or you can chat in the chat box.
Oh, this is Connie. As I said, I go to meetings, and when I present about this, and I have former patients come up and say, "You didn't give me any opioids." And I said, well, I wasn't very enlightened, but I just didn't think giving you a drug that would make you dizzy and constipated sounded like a good idea after you just had a baby. And they agreed, and no one was mad at me. But as I said, this is a different culture. I'd be really interested to hear what's happening in your hospitals to help enlighten.
Okay, let's have you talked internally with your opioid stewardship committee about enacting or having a facility-wide protocol for 0 days of opioids prescribed for uncomplicated vaginal deliveries? Or is this still just a per prescriber plan that's in place in your facility? And I'm sure there are successes and barriers you've seen regarding changes in prescribing habits. Feel free to share with those again in the chat box, or the lines are open.
I will tell you about a program that they did at Brown University. This is a resident paper that I heard presented. And she actually went into the electronic medical record. And as a physician, that was relatively new when I was electronic not prescribing, but looking in and just looking at what the patient had taken. How many opioids has that woman taken while she was in the hospital? And this resident did that and calculated if you, and there's a certain calculation you can do, that if Connie White took this many pills over this many days, this is what's predicted she would take in the next few days. And what she did was she did that calculation versus the standard of, oh, I always give 20 pills for this or 25 pills for that, because I know physicians that have that in their head. How many more pills were prescribed than what was actually needed by the algorithm if the physician had actually looked at the med chart and not just said C-section equals this many pills? I thought it was fascinating.
Okay. Well, it seems like we have. Go ahead.
I have a question for the group. I was in a very small practice. I was a solo OBGYN for 3 years back when I was a crazy woman. And then I ended up with, there were 4 of us practicing. We knew our patients pretty well since we were such a small practice. Do you think that having larger practices where people are rounding and don't know that person well, do you think that that might be leading to people saying what I was talking about, a standard of if it's a C-section, I give this many pills, and if it's a vaginal delivery, I give this many pills? Because I really don't know this woman very well, and I want to be sure that I give enough. And that's a pet theory of mine. Does anybody think that that might be happening?
Well, Dr. White, this is Emily again. Sounds like we have a quiet group today. That is an interesting question, and that seems logical. I definitely understand that you're thinking there. But Dr. White is always available, very approachable to contact, so feel free to contact her by email. That's listed on the screen. That's connie.white@ky.gov. And then also you can, if you have any questions or if you misplace her contact, you can always contact me or Melanie Mock at KHA. But today, this webinar does offer CE to the following disciplines: medicine, pharmacy, and nursing. We do have Kentucky SOS has submitted, and the CE is pending approval through the Kentucky Board of Medical Licensure for the House Bill 1 CE credit. Once I hear regarding either approval or not, I will send out to all attendees. So all live attendees, please look at your screen and you can download this. I will also send out this document to all the attendees today so that you can get your continuing education. You will notice, though, that this needs to be done by July 24th at 11:59 p.m. Eastern Time, or else it will be void. So the portal window is open until July 24th at 11:59 p.m. Eastern Time. So definitely go ahead and do that sooner rather than later. I will also send out to all the project leads the slides and recording for today's webinar that Dr. Connie White presented. And also this will be posted, both slides and recordings, on the Kentucky SOS website. So if you need to review or reference this or want to share with other providers, that will be on the Kentucky SOS website, which is spell out KentuckySOS.com. And you can find, stay up to date with all things Kentucky SOS with a new newsletter that we've just started actually the month of June. If you are not receiving the Kentucky SOS monthly newsletter and wish to, please contact me. Also, it is posted on the Kentucky SOS website for your review. Always check out the website. We are constantly posting new things and adding more resources and toolkits to make your job easier, because good things are happening here in the state, and we're all working together to further our opioid stewardship efforts. And as always, I'm available if you have any questions or comments, especially more and more facilities are starting to report their data. Our baseline data is from January to March of 2020. And I know some facilities took a break due to the COVID pandemic, very understandable. Please call me if you have any questions regarding data issues or email me at ehenderson@kyha.com. And Melanie, I will turn it over to you, please, for any last minute things that we may have, and I appreciate everyone attending today.
Great, thanks, Emily, and thank you again, Dr. White. Any last questions for Dr. White today, either in the chat box or on the phone? It looks like we did get a few responses, Connie, to your question. One hospital said our group is small, but they use the excuse that my partners don't stop, the patients wouldn't like it. And then another one said, I think a lot of providers simply don't understand MME.
Yes. Yeah, I think that's one of those, people just need to be informed. They truly don't see it. It's not something that, of course, when I say it's not taught in medical school, I was in medical school in the dark ages, but I think it is something that as you're doing this with your surgeons, I think we'll miss a big boat if we don't do this with our obstetrical community.
Great. Any last minute questions for Dr. White? Well, we do appreciate everyone's time today. Again, thank you so much, Dr. White. We appreciate you presenting today. Also, we all greatly appreciate the partnership that we have with you and your group. And we look forward to our next webinar, which will be in July, and you'll get information about that soon. Everyone have a great day, stay safe, and we'll talk to you soon. Thanks so much.